Okay, so assalamu alaikum to everybody. Good morning, good afternoon, good evening to all of you joining us either from Qatar or from different parts of the world. A very, very warm welcome to all of you. My name is Dr. Suhaila Chima. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine-Qatar and an Associate Professor of Clinical Population Health Sciences. So a very, very warm welcome to all of you again, joining us today for the Population Health and Wellbeing series. As a reminder, the objectives are showcased on the screen. You know, we discuss a lot of contemporary and critical topics relevant to healthcare, medicine, and population health. We examine evidence-based practices which are germane to public health and patient care. We also describe opportunities and challenges in the evolving face of healthcare and population health. Just some housekeeping. Your cameras and microphones have been turned off. You can use the Q&A feature to type your questions and comments. You can also post your questions and comments in the chat. So we will be able to see those. And as a reminder, the questions will be addressed at the end of the session, and I will moderate the Q&A session. This is an accredited activity, as many of you who may have attended the Population Health and Wellbeing series in the past. So it is accredited both by ACCME and also by DHP, which is the Department of Healthcare Professions Accreditation section here in Qatar. So evaluation and certificates, the post-activity evaluation, it'll be available in your Cloud CME account. By March 23rd, you will receive an email notification once the evaluation is available in your Cloud CME account, and your certificates will be available for download once you have completed the post-activity evaluation on the Cloud CME portal. So it's time to begin. We have a very, very exciting topic today: AI and digital psychiatry, challenges and opportunities. We have a fantastic speaker lined up today, and it is really my honor and pleasure to introduce Dr. Jyotishman Pathak today. He is the Francis and John L. Loeb Professor of Medical Informatics. He's Chief of the Division of Health Informatics and Vice Chair for Entrepreneurship in the Department of Population Health Sciences at Weill Cornell Medicine, Cornell University, New York. His research focuses on secondary issues of electronic health records and insurance claims data and clinical decision support for improving mental and behavioral health. His work has been funded by multiple major national grants from the US National Institutes of Health, NIH, the Veterans Health Administration, VHA, the National Science Foundation and the Agency of Healthcare Research and Quality, the American Foundation for Suicide Prevention, and several other private foundations. He's published over 250 papers, including many book chapters and invited reviews. He's a fellow of the American College of Medical Informatics, and he received his PhD in computer science from Iowa State University and a bachelor's in engineering and computer engineering from the National Institute of Technology, India. Dr. Pathak, a very, very warm welcome to you from all of us here in Qatar and around the world. So over to you.
Thank you so much, Dr. Shima and Dr. Mamtani, for this kind invitation. Let me go ahead and share my screen, and I hope you can see my slides.
Yes. We can.
Okay, fantastic. So let's go ahead and get started. When I got this invitation from Dr. Mamtani, I told him that this would be an area where we are actively working, not just in our group, but many of my colleagues, both here at Cornell and elsewhere. And so what I wanted to present to you today are some areas where there's a lot of research happening. There's, I think, a lot of potential for future growth. But at the same time, as I think we would all agree that AI is becoming such a new buzzword in a technology, probably some of you have heard about ChatGPT, that it also presents interesting challenges. So I wanted to sort of share with you some of the things that we are working on, but hopefully engage you in a dialogue. So let's move forward. Very quickly, I have this disclosures here, in particularly with respect to a company that I'm engaged in, but I'll not be discussing any unlabeled or unapproved use of drug or any products. Firstly, I wanted to acknowledge my collaborators, not only here at Cornell, but across many institutions here in New York City and elsewhere across the US, and very grateful for all the funding that we have received from federal, local, and foundations over the last 2 decades. So our objectives here are fairly straightforward. So first, I wanted to describe to you the role of AI, and in this case, focusing primarily in improving access to mental and behavioral health. And by that virtue, I think the same arguments could be made across the entire spectrum of medicine. But as I alluded in my opening remarks, as a new technology and as its adoption increases, I think it also presents many challenges. And that's where I think a lot of interesting conversations needs to happen between individuals who are engaged in clinical medicine, as well as in technology. And then I would leave to you towards the end potential research and training opportunities in this narrow area, not only here at Cornell, but across other opportunities. Now, as I understand, this is a really impressive series in population health and well-being that has been led by Dr. Mamtani and colleagues. In fact, the previous speaker from February, Dr. Lowenfels from New York Medical College, spoke to you about the role of AI and particularly and its implications with global health. So I will not necessarily dive into the basics of artificial intelligence, but rather I want to indulge you in a conversation with applications of AI, primarily in psychiatry and mental health. So very quickly, just to set the stage, these are some numbers, somewhat dated, admittedly, with respect to mental health challenges, at least in the US. By some estimates, 1 in 5 adults in America experience mental illness, and 1 in 25 with serious mental illness, such as schizophrenia and recurrent depression. Anxiety rates are much more higher, so are depression and bipolar disorder. And clearly it presents a huge societal burden, but also an overall burden to our health system. By some estimates, depression is now the leading cause of disability worldwide and a huge contributor to the global burden of disease. And in terms of patients, for example, who die by suicide, a significant proportion, upwards of 90%, have an underlying mental illness. Now, unfortunately, certainly here in the US, but globally as well, many patients who suffer from mood disorders and mental illness remain underdiagnosed and as a result untreated. And some of this is perhaps a factor why we see these sorts of figures and trends in terms of, in this case, rates of suicide and drug overdose deaths. Now, again, this is somewhat older data, but you can really see that how this trajectory is unfortunately going in the wrong direction and has continued to do so, certainly during the pandemic, where significant number of individuals died due to drug overdose in the last 2 to 3 years. And so this is a really unfortunate trend, and to address some of these concerns, the Substance Abuse and Mental Health Service Administration in the US launched a strategic plan a couple of years ago. In fact, they are in the process of creating a new strategic plan for FY23 and beyond. But it included essentially a sort of 5-point plan to improve the nation's mental health. And it had things like broader access to prevention, treatment, and recovery services for patients, expanding the mental health workforce, widen the use of health information technology, education of the public. And there's clearly huge stigma when it comes to mental illnesses. So education becomes a huge component here. And then, of course, investment in future research. Where my group and a lot of our work has focused over the last 10 to 15 years is really in this bullet number 3, where we are interested to see how technology, big data, and now more recently AI can really help us not only understand the risk factors and the causes that are associated with mental illness, but hopefully allow us to design interventions that can prevent, for example, someone from taking their life. And much of this work that I'll share with you today embraces this new medical data ecosystem, where it's not limited to just looking at patient self-report from surveys or looking at data from your mobile phones, but rather have this perspective of multimodal information, data from electronic health records, data from public health agencies, data from family history, and how all of these multimodal information can really help us understand the causes that are associated with increased risk from mood disorders. And this typically requires development of robust AI and machine learning algorithms to derive patterns and derive insights. And that is precisely what our group does. We analyze and signals and derive signals from health records, from insurance claims data sets. We have students working in social media, as well as mobile health. And in particularly, we spend a lot of energy around depression, substance use, and suicide. These are the three major conditions that we study. And the questions range broadly from ascertainment. Again, mental disorders are not necessarily well diagnosed or underdiagnosed, so ascertainment of these conditions becomes a very important problem. But then more pertinently, with respect to developing interventions, we want to create risk models. We want to look at outcomes analyses. And eventually, we want to deploy systems at point of care that can help our patients. Now, as it turns out, I just actually ran a query at ChatGPT as I was preparing for this talk, and I asked the question that how can AI really help psychiatry? Now, interestingly enough, ChatGPT actually agrees with some of the things that we are working on, that this technology has the potential for earlier detection, for personalization of treatments, assisting psychiatrists in early diagnosis and improvement in diagnoses. And of course, last but not the least, development of novel ways of providing treatment, either through chatbots and other virtual therapists. So on one hand, there's a lot of pushback against how these sorts of technologies can be used, but I think there's certainly a lot of opportunities here. And what I'll share with you today are a series of projects that we are working on broadly in depression and suicide, substance use, and also studies that we are underdoing right now in telepsychiatry. A huge asset that we have been very fortunate to have access to here in New York is a very large de-identified data set, which includes upwards of 15 million New Yorkers across all the 5 boroughs in New York City. And we have established this large research network called the Insight Research Network, where it links clinical data on these many number of individuals and links them with insurance claims data sets, with social determinants of health data, and also with patient-reported outcomes. So 2 studies that I want to present to you today, one which is using deep learning methods to look at depression subtypes, and another study that is predicting postpartum depression, leverages this particular resource, which has been established over the last 10 years and is led by my mentor and chair of our Department of Population Health, Renu Kaushal. So let's dive into some of these studies. So the first study was led by my postdoc, Zhenxing Zhu, with my colleague, Fei Wang, also in population health, and George Alexopoulos, who just retired from Department of Psychiatry. And as the title suggests, in this case, we were using machine learning methods and data from electronic health records to subtype depression. Now, as I said at the beginning, depression is a highly prevalent condition. By some estimates, lifetime prevalence of 17%, a huge societal burden. And at the same time, unfortunately, it remains underdiagnosed. By some estimates, 2 out of 3 patients who present with somatic symptoms in primary care setting remain underdiagnosed. So there's clearly a huge need in development of tools that can allow psychiatrists and other clinicians to identify individuals at risk of depression and provide preventative treatments. Now, this is a problem that has gained a lot of attention over the last several years. So I'm presenting to you some studies that were done almost a decade ago now. Very early on, there was work at Stanford where they looked at data on about 10,000 patients, in this case, electronic health record data, and develop these risk models that allow you to predict current risk of depression or depression within the next 6 months or depression within the next 12 months. Similar studies were done at University of Southern California, and in our own group, I had a postdoc who actually looked at data, in this case from South Korea, and developed these sorts of risk models that looked at demographics, comorbidities, disability status, and other social determinants. But what has been missing from a lot of these studies is this notion that when we are thinking about depression as a condition, it is really a multifactorial disease, where this is a schematic that's taken from a systematic review done by my colleague here, actually, Cornell University, Department of Psychiatry, where you think about that in terms of studying depression, you have to really consider this in terms of heterogeneity of the condition, where the top-down symptom-based, where you have multiple different symptoms. Someone is not feeling energetic, someone is not having a very strong appetite, someone is not getting proper sleep. So there are lots of symptoms that potentially might suggest that someone might be having or suffering from depression. But then there's also brain circuit dysfunction and other genomic characteristics that really come into picture in terms of parsing this heterogeneity. So as a result, when we think about depression as a phenotype, really it's actually the subphenotypes that ideally could lead towards ascertainment of traits which are eventually treatable with medications and psychotherapy and other sorts of treatments. So that problem in terms of how we can take this broader phenotype and dissect it into subtypes has remained under study. And so that's precisely what we set forward to do. In this case, again, looking at the electronic health record data from this Insight Clinical Network. And in particularly, we were interested in patients who were not only diagnosed with depression, but also were subsequently treated, in this case, with antidepressants. And we looked at some of the basic information that's derived from the health records, your demographics, comorbidities, procedures, medications, and so on. And conducted this case control match of about roughly 12,000 or so individuals to do this particular study. We used very straightforward statistical methods such as propensity scoring. We looked at actually the depth of the electronic health record to do matching between these cases and controls. And again, applied off-the-shelf machine learning approach called latent class modeling, which essentially allowed us to cluster these individuals across different buckets. In particularly, we use hierarchical clustering to identify these subtypes. And what we observed, as you can see in this figure, are essentially 3 separate clusters. Now, I remind you, this is data-driven cluster. There is no human empirical knowledge that was embedded. This is purely derived from data. But we saw 3 distinct clusters as shown in that particular heat map. So let me walk you through these clusters. The first cluster, cluster A, was the oldest, and the mean age was a little over 72 years old. Not surprisingly, this cluster also had patients who had highest number of comorbidities, such as hypertension, hyperlipidemia, and diabetes, so fairly commonly occurring conditions. And also, not surprisingly, they had the highest rate numbers of prescriptions in terms of beta blockers or SSRIs or protein pump inhibitors. So in other words, this was a cluster which we would consider to be the most sickest. The second cluster was the largest. Over half of patients belong to this cluster, slightly younger. But interestingly enough, this cluster included more women compared to men. And we observed higher rates of chronic pain and fatigue, fibromyalgia, higher rates of anxiety. Over 1/3 or close to 1/3 of individuals in this cluster had an anxiety diagnosis. And as a result, not surprisingly, we observed higher rates of opium alkaloids being prescribed to this particular cohort. And then the last cluster that we derived as part of this analysis was the youngest, and it had a smaller number of patients, but also had fewer comorbidities, fewer medications, but very high rate of anxiety and a very high rate of benzodiazepines, which was prescribed to this group. Now, one might argue that, well, these are clusters that may or may not necessarily make a whole lot of clinical sense. But we actually tried to see if there is some prior studies that would confirm these sorts of associations. So as it turns out, there are many studies that have, for example, identified relationships between patients with hypertension and depression, hyperlipidemia and depression, diabetes and depression, pain and depression. And so in many ways, what we observed through this purely data-driven analysis of routinely collected electronic health record data is that essentially we are seeing clinical reality of what is really happening at the population level. And in many ways, this is confirming what has been reported in smaller scale surveys and smaller scale epidemiological studies. So in many ways, I consider this as generation of novel hypotheses. And what we're doing right now is to try these analyses even on a much larger scale and a much larger data set. So not just looking at patients from New York, but we are part of this NIH-funded research network called the Mental Health Research Network, where now we have access to data on over 25 million patients across 16 different states in the country. And we are running these similar sets of experiments across all of these health systems which are part of this network. So I'm very excited on this journey. And in fact, this has led us to do additional analyses on these important questions. So for example, this is a study that just got accepted earlier last month, where we are trying to actually apply similar models, similar machine learning models to look at treatment trajectories. So in terms of patients who are being prescribed antidepressants, can we predict that are these individuals going to respond to therapy or they are not going to respond to therapy? Because that is clearly an important problem from a clinical point of view, where much frequently, unfortunately, a lot of this is trial and error. And so what we again observed in the data in terms of developing these models is that patients, for example, who have who score higher in their initial depression scale, in this case, based on their PHQ-9, the Patient Health Questionnaire score, or for example, patients who have recurrent depression or higher rates of anxiety, fatigue, and stress are more likely to actually not respond to treatment compared to patients otherwise. So anyway, this is also sort of reflecting clinical reality. And our hope is that we can build these types of models and make them available at point of care to psychiatrists, primary care providers, so that they can use them for guiding their treatment, for engaging patients in shared decision making. So this is one study that I wanted to present to you. The next study, also in the space of depression, is being led by my colleague Yi Zhang, along with some of my other collaborators, Rochelle Joly in OB-GYN, Alison Herman in psychiatry, and Megan Tercio, who was a faculty member in our department, which is also focused on using machine learning algorithms for predicting postpartum depression amongst pregnant women. And so again, very quickly, perinatal mood and anxiety disorders are also highly prevalent. By some estimates, 1 in 7 women, at least in the Western world, suffer from perinatal depression. These numbers are unfortunately much higher in Africa and in Asian countries. And here also, about half of these individuals remain undetected. And in fact, some recent data would suggest that postpartum deaths, post-perinatal mood and anxiety disorder is now the second leading cause of postpartum deaths. So clearly, it's a huge burden to our society. And as it turns out, there are several common risk factors that are associated with these conditions. So prior history of depression or anxiety or antenatal depression are strong risk factors for postpartum depression. But then there are also a lot of social determinants, individual level social determinants or more population level social determinants that play a role. So for example, lack of proper social and emotional support during pregnancy or in the postpartum period, or other life stressors such as unemployment and miscarriage are also strongly associated with increased risk of postpartum depression. Now, as it turns out, one of the main factors why these conditions remain underdiagnosed and undertreated is because the current strategies that are used, whether in terms of patient self-report using questionnaires, such as in this case, the Edinburgh Postnatal Depression Scale, or doing comprehensive screening through different apps, mobile apps that are available in your iPhone or in your Android, don't really offer very effective and an opportunity for early and timely intervention, because they are much more, they do not necessarily enable comprehensive screening, and clearly they are not personalized for an individual patient. And so what we set forward to do was the first step really is to see that can we glean insights from individual patient records and really classify individuals across these 4 buckets, from someone who is at a low risk to someone who is at a very high risk of active illness, and really develop clinical decision support along this spectrum from routine care to all the way to specialized treatment that could be given for addressing individuals who are deemed much more higher risk for active illness. So in this study as well, we looked at design a very simple analysis where we essentially looked at women between the ages of 18 to 45, so during their prime reproductive age, and looked at patients who had given a live childbirth and had a diagnosis of depression within 12 months. So in the 12 months of the postpartum period. So that was our target population. I'm going to skip through some of these details. We looked at multiple diagnoses code. We looked at antidepressant use. And in this first phase of the study, we actually just looked at data from Cornell and New York Presbyterian Hospital on about roughly 17,000 or so patients between 2015 and 2018. So before the pandemic phase. And as the schematic here shows, we applied fairly straightforward off-the-shelf machine learning methods, random forest, decision trees, gradient boosting, and so on. And really our goal here was to develop these models that can improve your specificity and as well as sensitivity. And once again, we used routinely collected clinical data. So your demographics information, your conditions, diagnoses, medications, lab measurements, encounters, emergency encounters, outpatient encounters, but also we looked at certain social determinants. In this case, we primarily looked at marital status, which was derived from clinical text. Marital status being a proxy of having poorer or good social support. Now, it's not always one-to-one correlationship, but it at least serves as a proxy. We developed an approach, or modified rather in this case, an approach called sequential forward selection. It's a greedy search algorithm that allows essentially to identify a set of features that allow you to maximize the discriminatory power. And we use some criteria in terms of how it can yield to higher area under the curve. So there are more details in our manuscript actually. And so here are some results. So first of all, we observed that in our data set of about 17,000 or so eligible patients, the prevalence of postpartum depression was barely around 7%. So this number, first of all, seems low because the literature would suggest that in general, the prevalence of postpartum depression, certainly in the Western world, is somewhere in the range of 9%, 8 to 9%, maybe close to 10% in certain populations, but our prevalence rates were lower. So right here, it already suggests that significant number of patients are underdiagnosed in our health system. Now, mind you, this is data from just this Cornell, and so we are doing experiments in the larger network and the larger data set. But nonetheless, it immediately suggests that there is underdiagnosis that's happening. We also observed that patients in the postpartum depression group were slightly older. They had higher pre-pregnancy BMI. They had higher rates of emergency room visits. And in this case, in this study rather, significant number of individuals who were in the postpartum group were white. Now, this is a reflection, I think, mostly of where Cornell University and Weill Cornell is situated in Manhattan, which type of populations it caters to. So I would not put much emphasis on the race here, but nonetheless, the other factors in terms of older age, higher BMI, higher ED visits are consistent with what's been reported in epidemiological studies. So what we did was develop these classifiers that would allow us to predict the risk of postpartum depression across the pregnancy period, right? So our goal here is that can we identify women at risk of postpartum depression as early as first trimester, right? So as opposed to after childbirth, if we can identify high-risk individuals 9 months in advance, then we can potentially think about preventative treatments and preventative strategies such as psychotherapy or other kinds of behavioral therapy that could be considered. So that was really our goal. And what this figure really shows is that the model that we developed was quote unquote stable across these 3 trimesters. So in other words, we achieved an accuracy of about area under the curve of about 0.86. And this remained flat across these different trimesters, which gives a lot of confidence that this model is performing fairly well, even at a very early stage of your pregnancy, and hence could potentially have some utility from a clinical decision support point of view. And so we did additional analyses, created a Pearson correlation, and what this figure really is showing is that some of the top 5 predictors were, not surprisingly, factors that have been also reported in the literature. So prior history of mental illness or active mental illness is a strong predictor of postpartum depression. Use of beta blockers, prior miscarriages, obesity, and ED visits. Again, things that have been reported in the literature also showed up as signals in our data-driven approach. So what we're doing right now are a couple of things. So first of all, we are, as I said, this study was done just using data from Weill Cornell. So clearly we are working towards replicating some of these findings. But also we are trying to actually parse information from encounter nodes, because right now our data we feel is somewhat imbalanced if we just look at diagnosis codes. So we want to apply other kinds of machine learning approaches, such as natural language processing, to parse clinical text, to hopefully make our data set much more balanced and in many ways maybe address some of the missing data information. But more importantly, what we are trying to do is to actually integrate these models within routine care. So here's a screenshot of a tool that we are developing right now. And currently we are in the process of doing some pilot experiments in actually implementing this within Epic, our electronic health record system, so that this tool is available to OB/GYN providers during their encounters with patients, outpatient encounters with patients, to primary care physicians. And we really want to understand how clinicians perceive this information. As you can see here, the tool shows some risk factors. It shows your score. It shows the trend line of the scores. And our goal really here is to understand how this information is being used for clinical decision making. Our hope is that eventually we want to do a larger scale randomized trial and trying to see if these sorts of machine learning driven tools are in fact helpful or not in clinical decision making. We're also trying to understand attitudes towards use of such tools for mental health care. So we did a large national survey, in this case, on about roughly 500 or so individuals. This work is still ongoing right now, so this is unpublished and preliminary data. But our really goal here was to, first of all, understand sort of general perspectives on use of AI for mental health care. Do people feel comfortable in use of mental health professionals actually using such tools? What are some of the concerns that might be there? And really try to understand and get the feel around these different dimensions of autonomy and beneficence, justice, trust, privacy, and transparency. And what we are observing is that there are certain themes that emerge in terms of attitudes towards use of AI. So first of all, clinicians, patients, family members really don't want a black box number that's being spit out, in this case by machine learning model. They really want to understand individual level risk factor and explanations behind what is driving a score. You know, if some patient has the risk of postpartum depression at, let's say, 0.83 versus another patient who has a risk at 0.73, are these meaningfully different? Is patient number 1 different than patient number 2? What is actually driving the risk for these risk scores? So individual level risk factor explainability becomes very important. There's also, I think, a lot of concern with respect to how these models are potentially using, or in many cases maybe misusing some of these data. And so public awareness on personal data sharing and use becomes a very important part. And then there is also themes that we are seeing, especially with respect to trust within the healthcare system and healthcare teams. So AI and these sorts of tools are in many ways acting as an assistant, as opposed to making decisions. It's assisting physicians and clinicians in making decisions, and helping them provide better care and in a more timely fashion. So again, this is very preliminary at this stage. This is not published yet, but we're trying to understand these sorts of attitudes towards AI. So as I said, I just wanted to present to you two very simple studies that we are doing right now. But we have a number of projects that are underway in applications of AI in psychiatry. We have studies that are looking at suicide risk in veterans. We have studies that are looking at mental health and substance use. And we have a really multidisciplinary project that's looking at polygenic risk scoring for mood disorders. It's a collaboration between Columbia University, Mount Sinai, and Mayo Clinic. So if anyone is interested in learning more, I'm happy to share sort of details. So to just wrap up, in my view, when we are thinking in terms of big data in general, I think first of all, it is critical that we have this multimodal perspective. The studies that I presented to you were limited to just data from electronic health records, some social determinants, but mostly from electronic health records. But I think it's very important, especially when we're trying to study mood disorders, that we have a broader perspective in looking at not just data from your phenotypes, but also genomic information and exposome. So what you eat, how you sleep, do you exercise, your population level social determinants, do you live in an area which is prone to crime? I think all of these factors really become important. And I would argue that a field like mental health, I think, is really primed to benefit from analysis of this multimodal data, and certainly AI and data science and biomedical informatics could really play a role in making sure that the data is more optimally used to drive research, education, and ultimately clinical practice. But at the same time, I think it is also critical that, especially when we are trying to implement these models for clinical care and make healthcare much more equitable, much more broadly accessible, that we need to have a cautionary view in terms of ensuring that these models are fair. These models are not actually injecting any bias. Already, patients are stigmatized, and access to mental health services is a challenge. So we do not want to make things actually worse. And I think that really is a concern broadly. So this is this international survey, in this case, actually was published around a year or so, or 2 years ago, actually, that included about roughly 800 psychiatrists from 22 different countries. And you can see that there's a huge proportion, almost 2/3 of in this case, psychiatrists, put a question mark in terms of use of AI and whether the benefits sort of outweigh the risks versus harms. And I think the goal as individuals who are working in this space is to make the yes slice, which is barely at 36%, ideally as close as possible to 100%. And I think that's going to require more time. And it's going to require a partnership. This is another data point from the same survey that I think there is strong optimism that eventually these tools will assist with clinical diagnoses, but we are several years away from work in gaining that confidence that these tools will essentially become a companion. It's not designed to replace a psychiatrist, but rather act as a companion to a psychiatrist and help in appropriate clinical diagnoses and offering treatment. And we're seeing some of this in certain fields, such as radiology and maybe in dermatology, where there is much more tighter coordination and collaboration between AI-based diagnostic tools and clinical care. If you're interested in some of these topics, I would encourage you to read this very recent article from my colleague here, Dhruv Kuller, who is also a faculty member here in Department of Population Health. And sort of broadly, he talks about sort of the history of how AI-based technologies have been used to care for patients with mental illness, a historical perspective, but more recently as well as tools such as how ChatGPT might be used. This just came out about a week or so ago, so really a fascinating read. But I think these problems are very, very timely, and it just, I think these are pertinent not just for the field of AI and psychiatry, but in general. I think there are many unanswered questions with respect to privacy, fairness, and explainability of these tools. Protection of individual rights becomes very critical. And last but not the least, I think there is a huge requirement to validate, quote, a goodness of fit, so that it allows us to make these systems more equitable and really facilitates in broader clinical care. So I think we need to answer these questions in order to earn the trust of the clinicians and of the patients and their families before these tools can be more broadly used. So if you're interested in these sorts of questions, we just launched a new institute of AI here at Weill Cornell. It's being led by my colleague here, Fei Wang, who is an associate professor in informatics. As part of this institute, not only we are trying to answer these types of questions, but there is a broad push in education. There is a broad push in training for students and fellows. So if any of this interests you, please reach out to me and or Dr. Wang, and we'll be more than happy to have a conversation with you. Clearly, all of this is a huge team effort. So here's my team of collaborators. Apart from being enthusiasts in AI and psychiatry, we are also big foodies. So you'll see a bunch of food-related pictures in my team. So I think with that, I'm going to just wrap up here. Here is my email ID, very easy to remember. We do extensive collaborations with other Cornell campus, in this particular case, Cornell Tech, also here in Manhattan. And so if any of this topic interests you or you would like to have a conversation, please drop me a note. I'm more than happy to engage you, and hopefully we can find opportunities for collaborations. So with that, I'll turn it over to you, Dr. Seema.
Okay, thank you so much, Dr. Pathak, for that wonderful presentation. Very, very exciting times, as you've said, for people with a health informatics background. I did want to sort of, start with the question which sort of alludes to, where you've ended with your presentation. So talking about, that the world is right now struggling with a shortage in mental health professionals and accessibility to psychiatric services, plus the high cost of the service. How do you think, AI could help with this shortage, cost and accessibility, for psychiatric and mental health services? Any thoughts?
No, I think that's a very great question, and one that I think the field in general is really trying to, is grappling with. I think the short answer is that the most immediate role of these sorts of technologies in facilitating broader access to care is in twofold. So number one is acting as a triage assistant, right? So when we, for example, see patients in our clinics, not everybody, for example, needs the most higher level of care. So can we use these technologies to screen individuals and really see if your symptoms are fairly manageable, if they are not very acute? Could you actually see get an early intervention? And that's where there are FDA-approved tools right now for virtual therapies and e-prescribing, either through chatbots and other kinds of digital assistants. So one example is really in triaging, and in fact, we're trying to do some of that in our own emergency, in our psychiatry emergency program with telepsychiatry, where we're trying to use these technologies for triaging patients who could be potentially managed with telepsychiatry versus patients who really need to see an in-person psychiatrist. So I think that's one area. The other area where I think equity and access really comes to play is in digital therapeutics. Here also, FDA, I think, has approved at least 2 such treatments that I'm aware of, which could be prescribed as a clinician. So for certain types of patients who might have a profile for side effects with more traditional types of treatments could be eligible to actually receive a digital therapeutic. If anyone is interested, there is a FDA approved drug by a company called Click Therapeutics. You may look it up. And I think there is increasing adoption of AI-based technologies in digital therapeutics as well.
Great. Thank you, Dr. Pathak. So Dr. Pathak, just carrying on that conversation here, I know that psychiatry was one field, which has been using, a lot of like telemental health, right from the beginning. And now y'all are trying to see how AI and big data can, help this field. So what do you think, how well trained are our doctors in training, and our healthcare practitioners also for that matter, right? Because we all work as a team in clinics and hospital setups. And what can we do to sort of, now really, make them aware, not only aware, but, how is training coming along? How is the curriculum shaping up for this field of AI and big data?
I think the short answer is very slow, which is unfortunate.
Yes.
I think as faculty members in medical schools and in graduate schools, I think there has to be more that needs to be done. Thirdly, engaging med students fairly early in their training process. And by that virtue, I would even argue all the way to your undergraduate courses where students who are even remotely interested in health needs to get foundational training in statistics, needs to get foundational training in study design and epidemiology, because I think these are the new tools and skill sets that are going to be critically important for the next generation of investigators, scientists, physicians, and so on. So I think there is more to be done. Now, I think, at least certainly I can see on our own campus that there is a gradual shift. We are injecting some of these modules in our second-year curriculum for medical students. We are actually about to launch a new PhD program in population health in our own department, which will introduce some of these concepts to both individuals who are at an early stage, but also the individuals who are at a much more advanced stage. So I think progress is happening, but I wish it accelerates a bit more.
Yes, thank you so much for that. And I know that at our campus here, also at a pre-med level, now we're introducing courses, doing pilot courses. So a lot of it is happening. But again, I think it'll take a little bit of time, for everybody to sort of get on stage with AI. So just a question about, risk models. I know there's a lot of work that you do in which there is risk modeling. So how well do you think, of course, you can tell us better, how well do you think these risk models work? How do we connect the modeling that you're doing or the algorithms which are being fed? How do we connect that to reality? What is happening in real life, in real patients?
No, that's a very, very great question, Dr. Chima. And I think there was a recent article, and maybe I'll share it with you, and maybe you can distribute it in the group later on.
Sure.
Where on one hand, the technology side has accelerated so rapidly.
Right.
But the clinical applications and clinical demonstration has lagged behind significantly. I think there was a JAMA article that came out maybe last year or so where there's less than 100 RCTs done so far in demonstrating, not just in psychiatry, but broadly across healthcare and medicine. Less than 100 trials, randomized trials, at least large-scale trials, have been done so far where people have attempted to demonstrate the utility of these tools. Whereas if you search for machine learning in medicine, there's probably thousands of articles that are out there. Right?
Okay.
So I think as a field, that is the need that we clearly there is a room for improvement in technology development. Do we need more faster models? Do we need models to be more accurate? I think we all need that. But I would argue what we need more is implementation of these tools in clinical care, maybe as a pilot study, maybe as a smaller scale trial, and trying to see how do clinicians perceive, how do patients perceive, how is your clinical workflow tailored now because you have this companion with you. I think that is what is needed, and it's going to then bring questions more so about equity and fairness and bias, because now you are trying to test these tools on real people.
Right. No, and those are very, very valid points. Thank you so much for sharing that. Could you elaborate a little bit more, since you've done a lot of work, and I know that you alluded to in your presentation also, about equity and about the models, that they should be fair. What does that mean, in the real sense, when, in practical terms? Can you explain that a little bit for our audience? Because you did mention that it's a huge concern. And of course, you've done a lot of work. So please, if you can elaborate a little bit on that.
Absolutely. So maybe I'll just take you back to the example I cited with our work in postpartum depression. If you remember one of my slides, I mentioned that a majority of our cohort for this first study included white women. So these are primarily women of Caucasian ancestry. And so now, if we take this model, for example, and try to implement in a population where majority of the patients are non-white, maybe African Americans or otherwise, it is highly likely that the model is going to generate biased results because it has been trained and developed primarily on individuals who are white. And so that is one example that if your underlying data set is not balanced, it can potentially introduce certain types of biases, and that if you do not check for those biases, then it can have unintended consequences. Sure. And so there are many ways to mitigate those things. One, of course, is to get a much more balanced data set. In some cases, it's possible. In some cases, it's hard to do. But then there are also other statistical methods that one could potentially apply in debiasing these types of tools. And that is an active area of work, not just happening in our group, but across many other labs where they are developing advanced statistical approaches to make sure that A, we catch the bias, and B, reduce the bias.
Yes, absolutely. So very, very important, I think, work that needs to be done in this area. I know you already referred to regulations in the challenges section. What kind of regulations, do you think as an expert, should be put in place? Again, you've done a lot of work. You are in this field, in the moment. What kind of regulations do you think as an expert should be put in place to help this field, this science,
Absolutely,
be more useful for us?
Yeah, no, that's also a great question. And if you, for example, look at FDA, they, of course, have a lot of rules and regulations in place for traditional therapeutics and devices. Right. FDA over the last decade or so, has created another class of devices called software as a medical device, SMAD. If someone is interested in Googling software, SAMD, software as a medical device. And that's a completely new category of FDA-approved products that are new to the agency as a whole. People who are engaged in approving those products and devices are fairly new in this space. And yet again, they're asking these types of questions. Have you done a phase 2 trial? Have you done a phase 3 and a phase 4 trial? What does it mean in terms of an AI algorithm going through phase 1, phase 2, phase 3 trial? So I think some of these, in many ways, this is uncharted territory.
Yes.
And so I think there are more questions, and I hope that we'll learn collectively as a community as we move forward.
Absolutely. Dr. Pathak, I think I'm going to the last question. So I know you alluded to really, talking about data and then, saying that we should obviously be opting and moving towards optimal use of data. So let me ask you this: what do you see or foresee in the future? Where are we going with this? And again, like you said, ChatGPT is there and so many other things probably in the pipeline. Where do you think this is going?
Yeah, that's a very broad question, Dr. Shima. So let me see if I can at least take a crack at it. I see a couple of dimensions, right? So first, as I think alluded to you, it is very critical that not just in mental disorders, but broadly across medicine, we have a multimodal data perspective. Right? Where we live, what we do, how much we sleep, how much do we have physical activity really impacts our overall health. So if we just look at diagnosis and treatment, it's not giving us the complete picture. So I think that multimodal perspective is very, very critical when we're thinking about these aspects. I think the second part is that here I see a huge opportunity for academic institutions to partner with the industry. Right? It's not so much of us versus them, but it's all of us together, much like how it happens in pharmaceuticals, much like how it happens in devices, where there is strong partnership between academia and industry. I think here as well, with the right set of guardrails, with the right set of policy framework and regulations, I think there is huge opportunities for institutions like Weill Cornell to partner with the right technology groups who can bring their sort of expertise and we can bring our expertise, and hopefully all boats rise together. So I think that's number 2. And number 3, we already kind of touched upon, is around education and training, because that is certainly lagging behind. We want our future physicians and researchers to be well versed with these sorts of tools and technologies so that when the time comes to actually use them, they are embracing. They know what the challenges and limitations are, and they're asking the right questions. We are not clearly there yet.
And I think thank you so much for sharing those insights and for your expertise, Dr. Pathak. It's been a wonderful hour. I think we've learned a lot to be done, and we can, I think, absolutely just be moving in the right direction if we have, the right guidance and things in place. So thank you so much again for doing this session for us. We would like to thank all our participants also joining us from Qatar and rest of the world. So thank you, Dr. Pathak, for doing this session again for us.
Dr. Shima and Mamtani for the kind invitation. I look forward to opportunities to collaborate. Thank you so much.
Thank you so much. So thank you, everyone. Thank you for joining us. And inshallah, we look forward to seeing you all at our future events. Bye-bye for now.